Okay, we're going to be going over the second half of our farm. Hello, Emerald. Hello, Karina. Hello, Latanya and Kelly and River and Devin. It is so good to have you guys here. Now, we are, like you said, we're all-in-one study resource. What we're here to do is what your faculty often doesn't have time to do, is to sit down with you one-on-one. You can slow things down. You can look at them. So we have lots of tools that can help you while you're in nursing school do better on your exams. And in fact, in our membership, I do an entire NCLEX review course that's specific to everything. It includes this pharmacology too. Now, we don't charge for separate things. It's all rolled into the same price. So if you do like today, if you're looking for more this kind of teaching for nursing school, we have all the content in nursing school, including women's health, pediatrics. We've got it all for you in these short videos that have lots of practice questions for you to actually practice with those. So we'll also teach you how to study if you use that. Now, a lot of you said you want the slides. Hey, they're on the platform. So you're welcome to grab those. Now, if you're not a member, you can use the code FARM20, and all you have to do, and you'll get a 20% off a subscription, and then you just send your receipt to that address, events@lecturio.com. We'll post this again, and then we will send you the slides from the first session and the second session. We'll send them all to you. If you're already a member, you have the slides there already, but we'll send you the updated ones that have the pretty blue coloring on them now if you'd like those. Now, this icon means that's going to be a 60-second overview. It's going to be fast because I'm hitting the most important points. If I was getting ready to study for the NCLEX, I would use this review. In fact, that's why I created it. That you could listen, you can't go back and reread your pharmacology text. You can't go back and study everything because you have lots of things that you're studying for NCLEX. So this is meant to be a resource for you for either a final exam in a pharm semester or getting ready for the NCLEX. It hits the highlights and the points that it seems most logical for them to write an exam question from. So let's start with neurotransmitters. Pretty cool here, right? Those are those little poop, 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 those little pink things you see being released because that's the neurons talking to each other. They're sending those chemical messengers. Now, we have medications that treat mental health disorders or challenges that interfere or help these neurotransmitters. So it starts there, right? It travels along that axon, and then it gets released. You see those right there. So that's the frame of mind I want you in, is thinking about neurotransmitters. And the next medications we talk about are going to be medications that interfere or get involved or engage with these neurotransmitters. And these neurotransmitters control lots of things, our mood, all types of things that we see in mental health disorders. I'm going to start with an old one. It's called a tricyclic antidepressant. And one time someone asked me, does that mean there's 3 antidepressants? No, it doesn't. But what it does is it blocks the reuptake of 2 of these special transmitters. There are 2 called monoamine transmitters. Now, they're also called norepinephrine and serotonin. That is their official name. That's their name as a transmitter. When you see monoamine transmitters, that's just the type. It's kind of what their structure is. So TCAs stop the reuptake of norepinephrine and serotonin. Why you care is if it stops the reuptake, then it's more available to be used. And the client will get more of the effect of norepinephrine and serotonin. And if we're using this to treat depression, that should give them more energy and to feel more motivated, like they can do things better than if they weren't treated. Okay, so as we're starting to talk about depression medications here, like TCAs, remember, these are going to mess with the neurotransmitters. We're specifically talking here about norepinephrine and serotonin, and TCAs will block the reuptake. Anything that blocks the reuptake means more of that will be available to the client. Now, you're probably thinking, why are you repeating that? Because these are the kind of things I want you to do when you're studying. Don't just read tricyclic antidepressants, okay, they block neurotype 2. Say, okay, so why does blocking reuptake help my client? And what is norepinephrine? And what is serotonin? You need to kind of slow down and ask yourself questions where you're doing that. Okay, so here's some examples of the drug names. Now, there's no way you're going to be able to memorize all of these, right? And unfortunately, they don't necessarily, they're not as easy to remember as like beta blockers. But you'll see that you have some end in LINE, MINE. So you've got some things to go by, but that's not 100% because you're going to have other medications like cardiac medications that end in PINE too. So just do your best. Here's some examples. These are ones that are more typically given, but keep in mind, you won't be able to memorize all of them. Okay, so we use this to treat depression. Well, that makes sense because we know that TCAs block which two neurotransmitters? Norepinephrine was one. What was the other one? Tell me in the chat. Norepinephrine was one. What was the other one? Serotonin. Yes. All right, you're on it. You are so with me today. Woohoo! You need to celebrate. See, you can get this. You can do this. You just need to, I love it. I'm just so excited to be here with you today. It's rainy and yucky today, but I'm super happy to be here with students who want to be safe nurses. Okay, now we can also use this one for chronic pain. So someone has fibromyalgia or migraines or even severe depression, this is a medication that might be used. This is not one of the new ones. This is one of the old guys. It's not usually the first one prescribed, but it can really help with fibromyalgia. That might be something else that you see it used for rather than just depression. But let's talk about the things I want you to watch for as a nurse, head to toe, on the types of things that can be a risk. This is a central nervous system drug. So keep yourself in mind, okay, central nervous system drug, I'm going to have some central nervous system effects. This one can also over-sedate the patient. And if they're elderly, this is a drug that really isn't preferred that we use with them. And if you do end up using it with an elderly client, they need like half the normal dosage that you would give a 35-year-old. So keep in mind, CNS medications with elderly are usually a really risky thing anyway. This medication is no different. So you're going to know that it can make them over sedated. They don't feel like themselves. But here's some more physical things that they might see. This particular medication can give them orthostatic hypotension. So either they go from laying to sitting or sitting to standing, then they're going to end up with a drop in blood pressure, puts them at an increased risk for falls. Another reason it's not great for elderly people. They can have some dysrhythmias or arrhythmias with it, and it can be really difficult on their heart. So this is why this is not a first-line drug anymore, because it has some serious side effects. Not everybody experiences it, but in an NCLEX or a final, they're not talking about everybody. They're seeing if you recognize that this patient is having problems with this medication. So with TCAs, it also has those metabolic things, and it's also anticholinergic. Well, when you see TCA, it's got a C. That will help you remember it's got some cardiac issues like the orthostatic hypertension, the arrhythmias, and the toxicity. It's got an A for anticholinergic. So if it's an anticholinergic, dry eyes, dry mouth, dry gut, you get constipated, you have blurred vision because your eyes are dry. Those are things that can help you remember TCAs, cardiac and anticholinergic. Those are kind of some big ones. Now, urinary retention comes along with the anticholinergic, right? That's what happens with an anticholinergic. It blocks that. So a good time to take it might be to take the medication at bedtime. So TCA, what is the C going to help you remember as far as side effects? Tell me in the chat. With TCA, what are the side effects? You got it. What does A mean? A refers to anticholinergic. Yes. Okay. Like I said, this won't be a predominant med that you see a lot, but you've got this down. Yes. And a lot of people say that, everything dries out, right? Good. Excellent. Nice. You guys are doing really, really good. Okay, so we just talked about one specific group of medications. And what's the main thing that drug uses to treat the medications? The group of meds we just talked about. What does it treat? We talked about TCAs. And depression. Okay, what's another non-depression thing that we can use TCAs to treat? So it's not depression, but chronic pain. Yes. Okay, so you see what we're doing? You take some information and then you pause and ask yourself some questions. Now, for those of you that you're answering, please stop for a minute in the midst of all the nursing school or even postgraduate nursing school and realize you're really working hard at this and you can do this. It just takes time to focus and to know what you know well. You're never going to know all of it, but know what you know well. Now, the next antidepressant, these are MAOI inhibitors. Before we ever get into this, I want you to know that MAOI inhibitors don't play well with just about any other medication, right? That's one thing about MAOIs. They just don't play well. We don't use them very often, but sometimes we need to use them. That's what happens. But here's how they work. Look at the name, monoamine. Remember, that was describing a type of neurotransmitter because we've learned about that with norepinephrine and serotonin. Oxidase, ASE, means it breaks something down, right? That's an enzyme. Monoamine oxidase, breaking down inhibitor. So an MAOI is going to inhibit or block the breakdown of the monoamine. Okay, so we got this. When you break it down, that's why we know it inhibits monoamine oxidase, which that is something that's in the nerve terminals, and it will increase the amount of norepinephrine and serotonin that's available when a patient has an MAOI prescribed. Okay, why? Because it inhibits the breakdown of these neurotransmitters. So let's go and I'm going to give you a picture so it's clear in case that was confusing. These are some examples of these medications. You've got some names there. And phenazine or Nardil is the one that you saw in your practice question last week. So when we talk about monoamine transmitters, neurotransmitters, examples are serotonin and norepinephrine. We already talked about those with TCAs, and dopamine. So these three are monoamine neurotransmitters. What their job is to relay signals between the nerve cells. Remember, we saw that picture of the neuron and the little round pink balls going through? But these three do some really important things throughout the body. Neurotransmitters do all kinds of important things. But after those neurotransmitters send a message in the brain, they're usually absorbed. And what absorbs these neurotransmitters, right? That's these three that we're talking about. What absorbs them is this protein that breaks it down. It's called a monoamine oxidase. We already talked about that, right? So it's a monoamine transporter. Now, if your brain, if too many of the monoamines are absorbed, then you end up with a chemical imbalance in the brain. And that's likely what we're trying to treat. This is what a monoamine neurotransmitter, that's how it works. So if they have too many of these reabsorbed, that's when you have the chemical imbalance, which is why we give a MAOI, an inhibitor. That's what we're looking to do. So these MAOIs have this weird diet thing. This is something that's worth your time in knowing. Know that aged foods, they contain something called tyramine. And tyramine is the building block of norepinephrine. Okay, so remember that? Norepinephrine, that's one of those monoamine neurotransmitters. We've got the medication. If they're on an MAOI, then we're going to block the reabsorption of that so they have more of it available. This is going to become a problem if the patient on an MAOI eats a food that has tyramine, because tyramine will end up with the patient having lots of norepinephrine. If your client has too much norepinephrine, really puts them at risk, okay? So MAOIs are medications that will block the reabsorption of those monoamine neurotransmitters. And if you do that, there's more of those neurotransmitters available, which can be a good thing. But if you have too much of it, it's not good. So since tyramine is a part of that, let's walk through what happens. What's key for you to remember is aged foods. MAOI cannot eat aged foods. Aged salami, aged cheeses, aged wines. They cannot do that because you're going to end up with a hypertensive crisis. Where does a hypertensive crisis come from? Because tyramine is a building block of norepinephrine, and you're going to end up with way too much norepinephrine. So you take the MAOI, your patient takes it, which is what's going to block the breakdown of the dietary amines. Then you're going to end up in your gut. You're going to have, if you have these foods that are dangerous for this patient, you're going to end up to hyperserotonemia, a really big word that means what? Hyper, elevated, serotonemia. You've got these neurotransmitters going around, and you're going to end up with all kinds of problems. So watch for foods that are aged and foods that are high in tryptophan. Because these drugs will inhibit, right? If they inhibit the breakdown of these, the body can't get rid of this excess norepinephrine. So if they're on the medication and they eat one of those risky foods, you're going to have super high levels of norepinephrine that could lead to a hypertensive crisis. Okay, so MAOIs, tyramine or aged foods, then you're going to have a hypertensive crisis. So MAOIs, you end up with aged foods, you're going to have a hypertensive crisis. Keep that in mind. Here's a list of the other foods to know. You can't memorize all these. You can't memorize all these. And, I was interested to learn that in some cultures, they eat the peel and the banana. So I didn't even know that was a thing, but it's not uncommon. So know that one of these questions could be reflected in your exam. Here's some other things. Remember, just look for groups and categories. You cannot memorize all of those. Just one of the best things to remember is aged foods. So this was the question that dealt with this, right? Which client statement indicates the client understands the teaching about receiving phenelzine? Okay, if you want to, you're welcome to put what you guessed in the chat. You do not have to. Don't feel any pressure. Okay, so I have these things, but before I look at the answer choices, if you will just do this one thing, it's going to change your performance on your exams. It says, which client statement indicates the client understands the teaching about receiving phenelzine? So I'm looking for the statement that is correct or safe about phenelzine. Well, this, since you know already, since we just talked about it, this is an MAOI. So when I'm taking this question, I don't even look at the answer choices yet. I make sure, am I crystal clear in what that question is asking me? Yes, I want understanding. So is this safe or correct about someone taking phenelzine? I know that phenelzine is an MAOI. What do I remember? Biggest risk. Oh, I don't want them to have aged foods. Okay, now let's look at the first one. Does I eat smoked salmon with cream cheese on a bagel every morning indicate that they understand the teaching about phenelzine? No, smoked salmon is aged, so I can get rid of that one. Well, you work through the other two statements and you look at, does B indicate that is it that correct or safe for somebody on the MAOI? No. What about C? My blood sugar is better controlled now that I'm taking phenelzine. Does that indicate correct or safe? No. And that's what I want you to do. You go through each answer choice and you eliminate it and say why. Make sure you know exactly what the question is asking you, put it into your own words, and then go through each answer choice one at a time, eliminate it, and say why. I promise you that will raise your scores. Now, if you want more test taking strategies, we have those all over the site, and I teach a full NCLEX review course. It's all wrapped into one. Now, D, I cannot take meperidine for pain control while on phenelzine. Does this indicate that they understand the teaching about phenelzine? Sure does, right? And that's how you want to do that. You want to make sure that you slow down and go through the questions. Remember, on NCLEX, the more you get right, the shorter your test is, and that's fabulous. Now, we talked about serotonin syndrome. This is what you should watch for. If a patient's taking a medication that puts them at risk for serotonin syndrome, we talked about neuroleptic malignant syndrome. They can also have serotonin syndrome with some psych meds. So what you're going to see are changes to their mental state. That can be sometimes kind of tricky to understand, but look for things like they're confused. Not that their mood is sad, but they're confused and they don't seem like themselves. Anticholinergic effects, but they can also have sweating or fever. They might have issues with shock. They're going to have some major signs going on. They can also have some muscle rigidity, but it is not as severe as neuroleptic malignant syndrome. This is why it's super important that you know all the medications that your patient is on. They're at increased risk for this if they are mixing medications. So you need one place where they have all their medications in one place so everyone knows what they're experiencing. So with serotonin syndrome, we've got the challenges, the symptoms for you over here. Remember, we're talking about the difference between the parasympathetic system and the sympathetic system. And with the serotonin syndrome, you're going to see that sympathetic nervous system in an overdrive. Now, this is rare, but if it happens, it's potentially life-threatening. So this sounds like a pretty good place for them to ask you a question about on NCLEX or on your final. So if you have something that puts that patient at risk for serotonin syndrome, then make sure you're watching for that. You're looking for any signs and symptoms that see things are not right? Am I seeing any of these signs and symptoms? And they tell me that they're on a history of these medications. You want to make sure that you are taking a look. Now, what are the medications? MAOIs and serotonergic drugs. That would be like SSRIs, MDMA, meth, other phenethylamines. These will increase the risk. The ones you want to really make sure you remember, SSRIs, MAOIs. Remember, those are selective serotonin reuptake inhibitors, meaning there's more serotonin available. MAOIs have more norepinephrine and serotonin available. That's why each of these groups, melatonin, MAOIs, and SSRIs, put your patient at an increased risk for serotonin syndrome. So if you're kind of following along at home, you know, like, hey, antipsychotics, neuroleptic malignant syndrome. Serotonin syndrome would be with MAOIs or serotonergic, and we saw the symptoms that they have. So if a client in the stem of the question is telling you that they are having these weird side effects and they're taking a psych med, this is what they're trying to see if you remember. Can you recognize that a patient is at risk for serotonin syndrome and is starting to show you some signs? Now, I said MAOIs don't play well with others, and I mean it. Particularly, meperidine was a good example, and that's what it was on the test too. But also, it doesn't play well with the friends we talked about first when we opened up, is TCAs. All of this is going to end up in a hypertensive crisis. So, MAOIs and meperidine, which you may know as Demerol, that's not a good plan. MAOI with any other antidepressants, not a good plan. And what happens is a hypertensive crisis that could end up being pretty severe and causing significant damage to your client, also depending on what are all the other issues. Now, we use this again. We talked about depression. Bulimia is an unusual one. I mean, it's different than what we talked about with the others. But bulimia, this is used as a treatment, people with OCD and with panic attacks. So while this is depression, you might kind of keep in mind the other things that it can be used for. So here's another list to kind of reinforce with you. Remember, MAOIs don't play well with others. They don't play well with anti-hyper drugs, with opioids like meperidine, other antidepressants like TCAs and SSRIs, and indirect acting sympathomimetic agents. That is a very long way to say something that indirectly activates or mimics your sympathetic nervous system, which is all the things going faster, right? That's the system that kicks in when you're in danger and you're trying to save yourself. So those are all the types of medications, really just not a safe drug anymore. We have better drugs unless for some reason what we're trying to treat or help you with is resistant to everything else. Okay, now, C, can you think back? We talked about two major categories of CNS medications. What are those two major categories we've just talked about so far? Tell me in the chat if you can remember. River, you nailed it. Yeah. And now what I would recommend is, you guys are all getting it. Now what I would recommend, like if we were studying together, which I would love to study with you, but if we're studying together, ask yourself, what are the similarities between TCAs? What are the differences? Like I would think about similarities like, they both end up with, right, extra neurotransmitters. They both have a risk for this kind of sympathetic nervous system overstimulation. Is there a dietary problem with TCAs? Not as much as with MAOIs, right? They have a lot more. So look for those types of things. I would recommend you write yourself some notes, draw some pictures. I know that you guys often get notes from people who've gone through the program ahead of you. Those are not nearly as helpful to you as they can be unless you write yourself notes on the side or you do something with it. Now, you know, on Lecturio, the platform, you can download any of our stuff. All our notes are there for you. You can practice with our questions. Even if you're not a member, we have over 300 cheat sheets, which are super helpful. But none of that is magic unless you actually do something with it to make it your own. That's what you're really looking for to do. Now, so we hit those first two. Let's talk about mood stabilizers. Now, we use these for all these things, right? We can use it for people who have schizoaffective disorder, people who have manic disorders, bipolar, someone who's having problems with impulse control or conduct disorders. We can even use it along with depression therapy. So this is a different kind of medication. This is a mood stabilizers. Now, we have a really old drug. It's called lithium, and lithium is a mood stabilizer. Now, lithium or lithium carbonate, that's a salt, and it can modify the messenger systems. It's actually old, but it really does some super cool things. But there's some unique things about lithium that I want you to keep in mind. Now, for this particular medication, you have to do a drug level. So that's a good thing for you to know, that this is one of the few medications that we give out of the hundreds of medications that we give that has to have serum levels, blood levels drawn regularly to make sure. The reason is because it has a really narrow therapeutic window. It means there's just a certain level that is safe and effective for the patient. Too much and it makes them toxic, not enough, and it won't treat it. These guys have to drink extra fluid every day. Really key. Have to drink extra fluid every day. We also want them to have a normal sodium intake, and I'll tell you why. Lithium, the kidneys, right? They control what gets reabsorbed into the body. The kidneys sometimes can't tell what the difference between lithium and sodium. So if someone drastically reduces their sodium, the body's normal response is going to be, hey, don't pee out all the sodium, let's hang on to it. But the kidneys can't tell what's sodium and what is lithium. So if someone has a abnormally low sodium intake, they're at risk for lithium toxicity. So you want to watch for that. You want them to drink 2 to 3 liters of fluid a day because they tend to pee out a lot, particularly when they first start this medication. Now, this medication, like many CNS medications, they don't start working. You don't know they start working. You're looking at 2, that'd be quick, really 3 weeks before you start to see it. So if the patient's in a major psychosis, then what you need to do is you need to make sure that you have another medication on board. Lithium should be taken with food, but listen, you can't memorize all that. What's unique, what's special about lithium is you want to know its similarity to salt and why a patient, which would be really hard to do if you're in the USA because we eat so many processed foods, but why a patient who drastically limits their salt is at an increased risk for lithium toxicity. So let's try another break to supercharge your memory. I want you to try and do this without looking at your notes. Not because I want to be mean, but just the act of trying to remember something is going to help you understand it and recall it when you need it. Okay, so here's your question. Let's take a look. How does a low serum sodium level increase the patient's risk for toxicity? Now, you don't have to tell me in the chat, but see if you can speak it out in a way that someone could understand what you're saying. So take 30 seconds and see if you could explain this to someone, how a low serum sodium will increase a patient's risk for toxicity. Okay, good. Remember, when there's a low serum sodium, the body would typically reabsorb sodium in the kidneys. But if you're taking lithium, it's not going to necessarily distinguish between the sodium and the lithium. So you're going to end up with a risk of toxic levels. Good job. You got it. Nice, Tom. You guys even wrote it out. I'm impressed. Okay, so what are the things you should look for if a patient's developing these things? Well, remember, this is one of the few medications that has to have regular lab work, particularly when they're just starting therapy. But therapeutic range is 0.4 to 1.3. Remember, now the NCLEX has normal lab values on it. Toxic is going to be greater than 1.5. If the patient is toxic, even if you don't have a level, someone on lithium starts being overly sedated, confused. They might have some tremors, be real sleepy. They tell you they have seizures. These are all danger signs that you need to immediately intervene. Now, if they have this nausea, vomiting, and diarrhea, this is something to be aware of with this medication, even though they're taking it as a pill, and that often causes nausea for most medications. This one, If you have nausea, vomiting, or diarrhea, could be an indication of toxicity. That's why you definitely would want to get a blood test to see what they are. Now, this one stands out even more. So think about it when someone's kind of out of it, they have a risk of falling, you're worried about them. But this drug specifically, they can lose their muscular coordination and their weakness. So in a test question or in real life, they might tell you things like, I'm tripping over stuff more, or I've noticed I've fallen more. These are danger signs, and that's what they're going to want to try and test you on. Do you recognize that if somebody on lithium is having issues with muscle weakness or loss of coordination, that again is a sign of lithium toxicity? So when you saw this question, right, Mr. Yos has a history of bipolar disorder. He's been taking lithium daily and has called the clinic to discuss a concern with the nurse working with the healthcare provider. Which of the following client statements is most important for the nurse to follow up on? This tells me it's a prioritization question. There could even be more than one correct answer, but I know what's particular about this patient. They have bipolar disorder and they've been taking lithium and they have a concern. So let's see what we can remember. I get very dizzy when I stand up. Is it important that I follow up with that? Well, that is one of the symptoms with lithium. So I'm going to keep it in there for now. Because remember, prioritization is always about seeing which one of these four is most important. I don't like taking medication every day. Well, that's something we'll take a look at. But really, I think A is still a bigger concern. So I'm going to get rid of B, where I get that we would follow up on it, but I think A should be followed up on more than B. It's a bigger safety issue. C, my legs don't seem to work right. Is that something that I should follow up on? Well, I know lithium has a risk for muscle weakness, right, and lack of coordination. So that definitely is higher priority than A. But remember, now I've gotten rid of A because C is a higher priority. And D, my mood swings are better. Do I need to follow up on that? No, that's great. That's what we want. So that's why I can say with confidence, C is the correct answer. We're thinking like, well, of course, we just talked about it. Remember, as you continue to study this, you're going to be able to do the same things on these pharmacology questions. I promise. Okay, now we're wrapping up the psych. Before we go on to hypertension, we talked about 3 main groups of psych medications. Can you type those in the chat? And don't worry about being fast. Just get your answer in there. What are the 3 main categories of medications we talked about with psych meds? Yeah, you got it. Now, as you're continuing to do this, and remember, put your answer in there. It doesn't matter how fast it goes in. It just matters that you have taken the time to think about it and to type it in. You're helping your brain remember these things. Now, I want you to think of a big risk factor that you can remember for TCAs. And do the letters in TCAs help you remember anything about that? So with TCAs, which of those letters can help you remember? Yeah, I love it. You guys are still putting it in. Okay, and with TCAs, C is for cardiac. Good. Good. Oh, I like that too. Good. Yeah, fantastic. Yeah, and you just get your answer in there when you can. Don't worry about other people and when they get it in, because it's all about, can you recall the information? And it's not a race. It's not a race. Because sometimes you get so hard on yourself. You compare yourself to other people and you just swear you're the slowest kid in the room. You're not. It's just everyone, things work differently. I'll take a nurse who's thorough over somebody who's impulsive anytime. Now we're going to move on to talking about heart stuff, right? We've done head, now we're going to do heart. Hypertension, because that's something we treat a lot of in the US, obviously. So let's talk about some key medications for that. Now, this is the RAAS. You've already talked about this in nursing school, likely many of you have, but this is the way the body helps raise the blood pressure. Now, that's necessary because we need good perfusion. Your blood is in your arteries and veins, and it mobilizes blood and serves it to all the parts of your body. So as your blood is moving through your body, that's what you want. That's a good thing. If your blood pressure drops too low, then it needs to be step it up. Or if let's say you need to run away from a bus that's about to hit you, well, you end up with angiotensin 2 at the end of the RAAS. And we're going to break that down simpler for you. First, you have renin circulating. When the body picks up, hey, blood pressure is not high enough to perfuse all my tissues. Then renin and the circulating angiotensinogen, which comes from the liver, they connect and they make angiotensin 1. Angiotensin 1 hooks up with angiotensin converting enzyme. That's known as ACE. Now that really matters, ACE, and I'll help you in just a second with that. When angiotensin 1 and ACE connect, then you end up with angiotensin 2. That's a bad mamma jamma, because angiotensin 2 is this, it's a potent vasoconstrictor. Just, we can't even make meds. They're that incredibly strong. It also causes the body to, it also stimulates aldosterone. And I say it like that so you remember, aldosterone, okay? That's a hormone, and it tells your body to reabsorb sodium, and wherever sodium goes, water follows. So there's two main ways that the RAAS elevates somebody's blood pressure. It causes potent vasoconstriction. Angiotensin 2, right, is a potent vasoconstrictor. And when you make those vessels smaller, you raise your blood pressure. And it also stimulates the release of a hormone called aldosterone. And aldosterone tells your body to hang on to sodium, and wherever sodium goes, water follows. So RAAS and vasoconstriction and volume expansion. More volume in those vessels leads to higher blood pressure. Now, when you look at this, you can do a whole lot of meds right from here. If you have a direct renin inhibitor, right, you're at the renin. If I have less renin, I'm going to end up with less angiotensin 2. If I have an ACE inhibitor, it means I have less ACE to convert angiotensin 1 to angiotensin 2. So then I've got less, right? If I have an angiotensin 2 receptor blocker, I'm going to have angiotensin 2, but all the receptors are filled up with the medication, or many of them are. And so angiotensin 2 can't connect to as many receptors. And so it doesn't cause as much constriction, and it doesn't cause as much stimulation of aldosterone, and therefore even less restriction, and you've got all this water coming. Okay, that's a lot of words. But what we just explained to you is the mechanism of action. If you just clarify in your brain what the RAAS is, R is for renin, right? The A's, angiotensin, ACE inhibitor, you've got all this in the system. This will help you recognize how things work. Direct renin inhibitors, that's all they do. Their name tells you what their mechanism of action does. With less renin, less angiotensin 2. ACE inhibitors, you have less angiotensin converting enzyme, less angiotensin 2. ARBs are angiotensin 2 receptor blockers. Ta-da! You've got them all right there. So this is the overall, right? You've got this. So you see where the adrenal cortex is the one that releases the aldosterone, and that is stimulated, right, when angiotensin 2 is in the body. Vasoconstriction, very potent. It's even stronger than old friend norepinephrine. So I've got this in here for you a couple times. Go back and ask yourself questions on this when you're studying and reviewing, and you're going to knock out several of those cardiac meds. So because we know your blood pressure is impacted by how much output, how much blood per minute your heart can pump out, and SVR stands for high SVR is a constricted vessel, low SVR is a wide open blood vessel. Now we'll talk about preload, afterload, and contractility, and we could go into that in our other sessions, but if you have questions about that, just let us know. So this is just a quick review. You already know this, just celebrate it. These are all the things that are involved, the 5 key main players that maintain a stable and normal blood pressure. These are the ways that we treat hypertension. First line would be diet and exercise. We try that with everyone, and that can be really effective. Now, there are some people that are marathon runners. They're super thin, trim, lean, athletic. They still have high blood pressure. But there's a large part of us that if your weight is more controlled, your blood pressure is more controlled. But sometimes it's really difficult for people to make major diet and exercise changes. So we'll start with a diuretic. And I want you to think about that. How could a diuretic lower my blood pressure? Well, a diuretic causes me to pee out, so I'll have less volume on board. That's how a diuretic helps you to lower your blood pressure. Yeah, Emerald, exactly. That is volume. It's a volume issue. So thiazides are kind of mild ones. The most potent ones are the loop diuretics, right? Loop diuretics like furosemide, those are going to be the ones that take the most fluid off. Now we've got the targets there. You guys already know that, so I don't want to spend a whole lot of time here for you on that. But I want you to be thinking about, hey, what are some ways that we can use the generic name of the drugs to help us remember what category it's in? Well, ACE inhibitors typically end in pril. ARBs typically end in tan. Beta blockers in olol, and calcium channel blockers in pine. Now remember, we had some psych meds that did too, but this is just a general rule to kind of help you remember these medications. Now, these are sympatholytic drugs, meaning they're going to go against a sympathetic response because we're trying to lower blood pressure because we're treating hypertension. Some are that you can use those types of meds. You can use direct vasodilators. We can use aldosterone receptor antagonists. Those are just all different ways we can look at it. But let's break it down. ACE inhibitors. Now, you remember they stop angiotensin 1 from becoming angiotensin 2 because they inhibit the production of ACE. Benazepril, captopril, enalapril, lisinopril. So these are ACE inhibitors. That's why we got a picture of cards there just to kind of help you with doing it. So we use it for hypertension. We also use it for people who had a tough hit to their heart, like a myocardial infarction. It can be protective for diabetic patients. And we do know that hypertension and diabetes kind of go together. Now, this slide, we put ABC here, but here I want to help you something that's even better, okay? With ACE inhibitors, there are 3 major side effects that I want you to recognize on any test question. A is for angioedema. That means that the mucous membranes in your mouth, they are swollen. So with angioedema, the person has this response and their tongue starts swelling up and it could close off their airways. So with ACE inhibitors, A is for angioedema. C is for cough. So A is for angioedema. Remember, that's swollen mucous membranes. It's going to be an airway issue. C is for cough. And E is for elevated potassium. So major side effects of ACE inhibitors, A, C, E. Angioedema, cough, and elevated potassium. So keep those in mind. Now, ACE inhibitors also can have a first dose effect. That means your blood pressure can be really low with the first medications. So as a safety thing, you might sometimes see in a test question, make sure they're lying down after they take it, or maybe they should take it at nighttime, but know that they have a real risk of that first dose effect. And these should not be used in pregnancy. I don't often spend a lot of time on pregnancy factors because there's a lot of things, but for this one, they definitely cannot be used in pregnancy. Now, side effects, they can have headache, fatigue. Fatigue makes sense because you're lowering their blood pressure, right? Cough, because we know ACE, we got that. The angioedema, we already got that. Elevated potassium, we got that. Orthostatic hypotension, hey, we start messing around with how their body responds. With blood pressure, they're going to be at risk for orthostatic hypotension. Now, vasodilators can have a bigger risk for orthostatic hypotension, but ACE inhibitors can too. They might also have some minor changes in their lab work, in their kidney output, like their BUN and their creatinine, and they might have some protein in their urine. That would need to be assessed as a trend and how that is going. Okay? Yeah. Christine, I'm glad you're welcome. Anything I can do to help you remember, I will do it. I have long lost my sense of, there we go. So let's take a look at this question. So the nurse assesses a client who is taking spironolactone. This is a potassium-sparing diuretic daily. The healthcare provider has just ordered captopril. Which action is most important for the nurse to implement? Well, I'm not ready to look at the answer choices. So I'm a nurse. I'm assessing a client who is taking a potassium-sparing diuretic. Side effects of that, it's mild, it's gentle, but their potassium is definitely not going to be taking a hit. The healthcare provider has just ordered captopril. Okay, captopril is an ACE inhibitor. I know edema, cough, and elevated potassium. All right. So, should I assess the client's heart rate? Now, is that most important? I don't think so, but let me look at B. Educate the client to take the first dose at bedtime. Okay, that's good. I'm going to leave that in. So I'm not so worried about the heart rate with an ACE inhibitor, but I'm going to leave B in because I know that has a connection to ACE inhibitors. Assess the client for any history of GI bleeding. Would there be any connection to captopril and GI bleeding? And auscultate the client's lung sounds. Well, that kind of sounds like a good thing to do, right? Because, nope, I've got to pick something. Well, based on this medication, question is about captopril because they just ordered it. And is there any problem with captopril and spironolactone? So what did you pick? Yes, it was B. Okay, GI bleeding doesn't have a connection. That's why I threw that out. Auscultate their lung sounds. I mean, it's always good to listen to their lung sounds, but the topic of the question is the captopril. So that's why B is a better answer. And I know those priority questions are so tough because should you assess the client's heart rate? Sure. Should you ask them if they have any GI bleeding? Well, it's not a bad thing to do. Should you auscultate their lungs? Sure. But what they're trying to test you on is what is most important. So that's why it's a real brain thing. Because when you took your prerequisites before nursing school, the questions had a right and wrong answer. In nursing school, we're always asking you to prioritize or apply information. So it seems like on some days you can talk yourself into any answer. Remember, the reason it's B, you want them to take the first dose at bedtime because there's a first dose effect. And they can have a really too big a drop in their blood pressure, which puts them at risk. So if you want them to take, that's one of the things, that's great because now we can talk about it. That's why with ACE inhibitors, it's a good idea that they take it at bedtime just so they're safe. That's for the first dose. They don't have to always do that, though. Okay, here's your turn again. Supercharge your memory. Try this without looking at your notes. You ready? Okay. Oh, what can you remember about ACE inhibitors? Is there anything new that you learned today that either you needed a review or it was new to you to learn about ACE inhibitors? Good. Yeah, my mom actually had this reaction with an ACE inhibitor. It was crazy. She doesn't take ACE inhibitors anymore. Good. All right. Yes, and I hope you're starting to wrap your brain around. I can't know everything, but I can sure know some things really, really well. That's what I want you to know. Excellent. Okay. Now, angiotensin 2 receptor blockers. I'm going to ask you a question. Does a body go through the complete RAAS, and is there angiotensin 2 available in the body? If someone's taking an angiotensin 2 receptor blocker, based on what you know about the RAAS that we talked about, will they still have the same amount of angiotensin 2? They will. Remember, this just means that angiotensin 2 doesn't work until it connects to a receptor and activates that cell. These guys won't be able to get to the receptors because they will be blocked by the medication. Fantastic. So you don't end up with the response that we typically would get with angiotensin 2. We don't have that potent vasoconstriction. So olmesartan, telmisartan, irbesartan, losartan. You've got those medications as angiotensin 2 receptor blockers. Now, side effects, you can still have a risk of angioedema. There's a lower risk of cough, and you won't have the potassium. So that's why if the patient has any of those problems, we can switch them over. If they have cough is a problem, we could switch them to an ARB and see if that's better for them and doesn't cause them to have a cough. Because we used to think the cough was not that big a deal, although it is kind of annoying, but we used to think it's not that big a deal, but we found out that, it kind of does scar your lungs. So it does actually impact if you did it long term. So first two medications categories that we've talked about in hypertension, what have we talked about? Can you list them in the notes? Yes, Donna, the cough can really be awful. So what were the first two categories? ACEs and ARBs. You got it. Now, in your mind, once you've got a chance to write it in the chat, in your mind, can you explain the difference in the mechanism of action, how they work between ACEs and ARBs? See if you can do that to yourself and speak it out loud. If there's people around you, they're going to think you're crazy, but speak it out loud. Okay, that's the kind of questions I want you to ask yourself when you're studying. Now, beta blockers, labetalol, propranolol, atenolol, metoprolol, these are all olols. Like, I gave you a big football blocker there to think. These guys also connect to receptors, and they stop what those receptors normally do. So they don't allow those sympathetic nervous system, those receptors, to be stimulated. So you don't have the same effect as you would with norepinephrine and epinephrine. Now remember, now we're kind of talking about below the brain. We're talking about what those do in the body and how they help stimulate or cause that sympathetic system stimulation. So beta blockers, you've got beta receptors. Beta 2s are on your lungs, and you have 2 lungs. Beta 1s are on your heart, and you have 1 heart. Okay, so that's predominantly where they are. You also have some on your uterus, which that makes sense, because if you're going to stimulate your sympathetic nervous system and you need to run away from danger, you do not want to be dropping a baby out while you're doing it. So they're also on your uterus. But with these medications, I want you to be thinking about the difference between, do they mainly hit the receptors on the heart, or do they hit both? If it's mainly hitting the receptors on the heart, it's cardioselective. But keep in mind, even if you get enough or a certain amount of a cardioselective beta blocker, it can still hit the ones on the lungs. Now, why do you care about this? Well, in a sympathetic response, remember, beta adrenergic, it's a sympathetic. The beta receptors on the lung, their job when they're stimulated is to cause what to happen in the lungs. If you want to run and you want to get away from the danger, what do you need your lungs to do? Tell me in the chat. Yes, I want the lungs to bronchodilate, to expand. Yeah, there you go. Now, if I give you a beta blocker, it's going to block that response some. So that means if I'm somebody with asthma and I start to have an asthma attack, I need that response. So anyone that has a beta blocker and a breathing problem, that is bad news. Beta blockers and breathing problems are bad news. Beta blockers and breathing problems are bad news. You want to make sure your clients know that when you're educating them about their medication, just in case. So we talked about non-selective versus selective, so you'll have that in your notes. I told you which ones were which. I don't know for sure. That's probably a lot to keep in your brain, but you've got it there in case you want to take a look at it. Now, we use it for chest pain because it'll decrease the workload, right? The heart's not beating as fast or as hard. That's good for somebody that has chest pain, because chest pain is a way of your heart telling you, I need more oxygen, right? After an MI, your heart's kind of limping, so it's good that they have less of a workload. They used to treat hypertension because you won't beat as fast and you won't beat as hard, so you will have a lower blood pressure. If someone's heart, cardiomyopathy, they also help with workload and how hard it works. And for the supraventricular arrhythmias, they can help kind of calm the heart down. Now, there's all these other things that we use beta blockers for, because think, when you're anxious, you're in sympathetic nervous system overdrive. In fact, I've had really good luck, and I always try to tell students this. If you have true exam anxiety, not the, oh crap, I didn't study for this kind of anxiety, but you sit down and take a test and your pulse races and you feel like you can't think straight, if you go to your nurse practitioner or your healthcare provider and tell them what you're experiencing during a test, that you actually have physical symptoms, then they can prescribe a low dose beta blocker that you just take on exam days, and it will make a world of difference for you. So I've had such success with low dose beta blockers. Obviously, it's not addictive. There's no street value, and they're really, really cheap. So you won't have a hard time getting a script, and they can write that for you. You can just take it on test days. Makes all the difference. Yeah, River, I'm glad you, yeah, they do. Yeah, they work really, really well. Now, we talked about the beta blockers. See if you can explain to your mind, explain in your own how a bronchospasm, right? Let's think about a bronchospasm. What's the connection between bronchospasms and beta blockers? Can you remember? Yeah, Karina, if you can do the work without any problem, then that's fine. Okay, remember the beta blockers mess with they block the response of the beta receptors on the lungs. Impotence. This is why this is not popular with a lot of men if they have that side effect. So that becomes a compliance issue. So what should you teach them? Now, this is specific to beta blockers because this is one of the medications that directly reduces their heart rate. So you want to make sure your patients understand that they should hold the medication if their pulse is less than 60. This is in textbook world. If you're on an NCLEX exam, normal heart rate is 60 to 100. If they're anything less than 60 on an exam, you want to really reflect on that, hold the medication, contact the healthcare provider. In real practice, the physician is likely to let their pulse rate go much, much lower. So it's going to be different in real practice than if you're taking an exam question. So pulse rate is something you want to teach your patient about. If they have any shortness of breath, they need to let you know about that because of the beta receptors on the lungs. And if they are diabetic, remember the biggest risk with insulin is for your blood sugar to drop too low. One of the signs and symptoms of a low blood sugar is a fast heart rate because your body is trying to kick that sympathetic nervous system response in because it wants to tell your liver to dump out that stored glycogen for energy. If you're diabetic and you're on insulin or you have risk for low blood sugar, you won't have that rapid heart rate. You will be confused, but you won't have that. River, absolutely. You can expect to see NCLEX that imply things like, no. Okay, I see what you're saying. Let me go back on that. No, on the NCLEX, the normal heart rate is 60 to 100. They will not do that to you. Normal blood pressure is 120 over 80. Yeah. No, that will not happen. Great question. Sorry, I misunderstood it first, but there you go. Cool. Yeah, and you had, River, good. You really got some great stuff. Great questions. Now, here's some calcium channel blockers. Here's another group. So calcium channel blockers, in that pine, a lot of them, the Piazam, you've got all these meds in here as examples for you. Do your best to keep familiar with some of those. But calcium channel blockers, this is what they do. Because when calcium enters, it has vasoconstriction, and it'll increase the heart rate. So if you have a calcium channel blocker, then you're going to stop these medications, stop the calcium from going across these cell membranes and the vascular smooth muscles. So calcium, no, River, I love it. You're welcome to ask any questions. Calcium channel blockers, because they stop that, there is less vasoconstriction and there is a less higher heart rate. You also end up with dilation of the coronary arteries and the peripheral arteries. So this is really good for somebody who's having chest pain, long-term treatment. So the calcium channel blockers don't mess with the veins. They don't really vasodilate those, but they do dilate the arteries, the coronary arteries, and the peripheral arteries. So calcium channel blockers, that's why they can be used as a long-term treatment for chest pain because it dilates those coronary arteries. They do just what they say they do. They block that calcium from crossing the channel, so you therefore have less of the vasoconstriction. Okay, so they increase the vasodilation. We're talking about the arteries. Some of them will directly decrease the heart rate. They help with afterload because they stop those arterioles from constricting. And they can also help, some of them can help with cerebral vasospasms. Well, I told you about that. I don't really expect that you would be able to memorize that, but they can be really good for that if someone's having cerebral vasospasms. Okay, so for treating hypertension, there's certain calcium channel blockers. If we're trying to get them to directly decrease their heart rate, you're going to look for something more like verapamil or diltiazem. If it's long-term prevention of angina, you're going to look for these medications. If you can kind of put that in your mind, that's great. That wouldn't be my highest priority, but I wanted you to be aware of it. So what are the side effects? Headache. Now you think about how many of these medications that we've talked about, that headache is a side effect. Dizziness and weakness. Hey, any blood pressure medication could potentially cause that. Palpitation and arrhythmias, now that's something different. Not all of them cause that, but some cause dysrhythmia. So you know the strategy. Make yourself your own chart that lists all the side effects and look for the medication categories that have similar ones and that have different ones to each other. Bradycardia and heart block, yeah, this is one that goes directly after your heart rhythm. Orthostatic hypotension, we know that technically anything that lowers your blood pressure can put you at risk for that. Okay, so you've got these all across the board here. Headache, might feel a little dizzy, weakness, but this one has the ability to directly slow my heart rate down. Some of them do. So that's why I'm worried about, wow, somebody already has heart conduction issues. This wouldn't be the drug of my first choice. Now, what is two things? I want you to think of two things that you have learned most recently about calcium channel blockers. See if you can remember two things. Okay, and we always try to help students know that asking yourself questions is the best way, even if you don't know the answer. But trying to answer a question is the best way for you to remember it. Now let's do some more cardiovascular stuff. We'll get you going. Remember this question? You got a client who's receiving digoxin. Which statement made by the client would require the nurse to intervene? So it's asking me for someone on dig, which statement would be wrong or unsafe? Okay, I've been experiencing nausea for the past 3 days. Well, I know nausea can happen with a lot of meds, but is there any connection to dig? Yeah, I'm going to keep that one in. Do I need to intervene for someone on dig if they say I keep all of my medications in a separate container? No, that's good practice. For a client getting digoxin, do I need to intervene if their arthritis pain is becoming more severe? No, because the question is, yes, I'm going to do something about that, but the topic of the question is digoxin. For a patient on digoxin, do I need to intervene if they say my mood swings are better? That doesn't have a connect. So I go back up to the one that I picked. Nausea and vomiting for the first 3 days. Who knows why A is the correct answer? What is A? Why is this a problem with this particular medication? Yes, it's a sign of dig toxicity. Good job. Remember, I told you that, yeah, nausea isn't a really big deal, but there are certain medications, it's a huge deal. And and digoxin is definitely an example of that. Okay, let's do some 60-second overviews. So take just a second and do a stretch, because we're going to take a stretch and do a nice big breath, because we don't take any breaks through this, and we've got about 19 minutes left. So I want to make sure that you're ready to go with us. Let's do some quick highlights. So statin drugs, they end in statin. They're used to lower cholesterol. Remember, these can be a little hard on your liver or in combination with other drugs. So think about the liver when they're on statins. Watch them for signs that their liver having trouble. Might be things like they feel real tired, they don't want to eat, they have some pain in their upper abdomen, their urine has changed, or they have yellowing of their skin or eyes. Those are all symptoms that you can observe with your eyes about someone who might be having liver problems. And I'm worried about that for somebody who's on cholesterol or statin drugs. Chest pain, nitroglycerin, 1 every 5 minutes up to 3, morphine. Oxygen is really only recommended if their SAT is too low. We used to give everybody oxygen. Now we really just do that if their SAT is too low. Long-term treatment are things like beta blockers, less of a workload on the heart, less of a need for oxygen. Calcium channel blockers, same thing. Nitroglycerin, same thing. We're helping lower the workload on the heart so that they can have less need for oxygen. So statins in chest pain, thrombolytics, these are the clot buster drugs. They have to be given within 4 hours of the onset of the pain. Why? It's a high cost drug and it's a high risk for hemorrhage. So we don't want to give it to anyone who we know has a known risk of hemorrhage, because it will rip through every clot in the body, not just the one that's, blocking the blood supply to the heart. So you don't want to give it to anyone who's had a recent trauma. CPR counts as trauma. So they have a recent trauma, a recent surgery, they have a history of GI bleeding, they've had uncontrolled, untreated hypertension, And again, or like CPR, which would be any kind of trauma. So if someone comes in with a car accident, even if the MI caused the car accident, they can't have these medications. Has to be given within 4 hours because they're high risk medications. They have to have lots of screening, and that's what they want to do. Sarah, they can also give this drug for stroke. If they take them to the lab and they take a look at, they do some scanning and they see what the problem is, then yes. Same thing. If it's a stroke, if it's an ischemic stroke, they would give it. That means it had the blood supply has been blocked. If it's a hemorrhagic stroke, absolutely they would not give it, right? Because they're already bleeding and that caused their problem. Now, heparin is usually, the protamine sulfate is for the overdoses. Heparin is typically in the hospital. Coumadin is in the community. These are old drugs, old drugs, right? Coumadin is, there's much better drugs out there now. Coumadin, you have to really mess with any drug that has, any food that has vitamin K, they can't eat because vitamin K is the antidote for an overdose. So dark green, leafy, healthy things, if they really want to eat a kale salad every day, they have to eat the same size salad at the same time every day to keep their Coumadin correct. And they have to have a PT and INR. Low molecular weight heparin doesn't have to have lab monitored, but they can do some lab work to keep an eye on it. We've got the ability to do that now. So protamine sulfate is what's given for a heparin overdose, vitamin K for a Coumadin overdose, and each of these prevents a clot from getting bigger and new ones from forming. That's what's different about these than a thrombolytic. So we look at the lab work and stuff that they need. Low molecular weight, they don't have to, but we can draw labs on it. Okay, IV solutions, you ready? We're picking up speed. Remember, you're going to have to go back and look at this on your own, but you can so do it. So we know that fluid is one of two places, inside the cell or outside the cell. If it's inside the cell, it's just inside the cell. If it's outside of the cell, it's either interstitial around my tissues or it's intravascular in my veins and arteries. Got it? So if it's not in the cell, it's either kind of in my tissues, between the cells and tissues, or it's in my intravascular space, which is my arteries and veins. That's where our fluid is. Now, whatever IV you hang, you impact the movement of fluid. Okay, so if it's an isotonic solution like normal saline, then fluid is not going to shift. Remember, fluid here in this little red cell, that is inside the cell, intracellular. And we're going to see where are things going to flow. Now, there's two other kinds. Isotonic means it is equal to what the tonicity is of my bloodstream. Hypotonic means it is lower tonicity than my bloodstream. Hypertonic means that it is a higher tonicity. So don't let this throw you. We usually look at sodium. Normal saline, 0.9% normal saline. That is an isotonic solution. There's other ones. Hypotonic is going to be lower than that. Hypertonic is going to be higher than normal saline. So hypertonic could be like something that's 3%. That's really, be ultra careful when you give something like that. Well, you should be careful with any IV fluids. But hypotonic, when you put something into the bloodstream that has a lower tonicity, now it's more concentrated inside the cell. So fluid is going to shift from the intravascular space into the cell. That's why it's risky for someone with elevated intracranial pressure, because if the cells in your head swell, you're going to elevate the intracranial pressure. So I don't want to give a hypotonic solution like half normal saline, which is, right, half normal saline is less than 0.9% normal saline. That's why I don't want to give it to someone who has a head injury because they already have brain swelling and problems. When the fluid shifts from the intravascular space into the cell, patient's blood pressure could take a big dip. That's a problem. You could also end up with fluids third spacing. Now I'm going through these pretty quick because I'm hoping it's a review for you and not a first time learning. If you're learning it for the first time, got a whole series of that for you to help you learn it. Now hypertonic, I put that in your bloodstream. That means that, wow, you're going to have these dehydrated cells because it's going to be more concentrated in the bloodstream. The cells are going to dump out all the fluid they have, and they're going to be dried up like little potato buds, very, very dry. So it's all about the osmolality, the osmolarity. Don't worry about that word. Here I've listed all the fluids for you so you know which one is hypotonic, which one is isotonic, and which one is hypertonic. This is just how we measure that, and that's how they've got this name. But this title tells me this shouldn't cause fluid shifting either way if I'm giving it an appropriate amount. This one and this one will cause fluid shifting. If it goes in the cell, your blood pressure could drop. Also could cause the cells to swell, which would be a risk. If it's hypertonic, the cells are going to donate all their fluid, and then they don't work well. I know that was super fast, but just so you know, you've got it there. Here's what the isotonic solutions are. It's their osmolarity when I say they're normal or they're about the same. You've got it there. So if I want to increase the volume that's in the intravascular space, let's say they just were out doing football practice and they're just super dehydrated intravascularly, then we're going to give an isotonic fluid. That's just going to fill that back up. But if it's a little grandma or an elderly person or someone who has a history of CHF, listen to their back, their lungs. In the back and the front, the first place they could develop crackles, which are a sign of fluid overload, is back and bases. It can also be in the front, but keep it in mind, before you give a medication to an elderly person or somebody with an IV, elderly person or someone who has a history of CHF, make sure you listen for crackles before you start and you assess them very regularly for it. So I've got these listed here for you. These are just references for you, so you have them and the reasons that we use these specific medications. Special notes with normal saline, just don't overload them. You overload them or they have renal problems, that's going to be a bigger problem. The lactated ringers, if someone has liver disease, they can't metabolize the lactate well, so this isn't the best choice for them. Now, D5W, it's isotonic in the back, but once that body metabolizes the dextrose, then it becomes hypotonic, so keep that in mind. Again, I know we're going fast here, but we've got these here for you where you can go back and review them and think through why that is. Hetastarch and Normosol are just volume expanders. Right, so they're supposed to go in your intravascular space, just kind of beef it up. You don't see this given a whole lot. I just want you to be aware of it. So when you're going back and reviewing these slides, you ask yourself, why is someone with an elevated intracranial pressure at risk to take a hypotonic solution? It's because that causes that fluid to go into the cell. And see how those guys are getting all swollen up? We want you just to keep that in mind. We've got the solutions here for you. I'm going to keep going through these because we don't have a lot of time to stay on those, but we have a full series on that. The reason you don't want to use half normal saline for burns, liver disease, or trauma, something I want you to keep in mind is it's going to cause hypotonic. It's going to cause that fluid volume shifting, and these clients are really fragile and at risk for that. Here's more information that we've just talked about hypertonic. When you have a chance to go back and to review that, because I know that these are a lot of slides there with information. All right, so let's get to this question because I want to try to make it all the way through 8, 9, and 10. Yes, you can review the slides if you're, Miss Brenda, would you help if you know how to, and she can take a look at the slides? Okay, so let's go to a client in the emergency department who is admitted with abdominal trauma after a motor vehicle accident. So the client's vital signs are heart rate of 126 a minute, blood pressure 90/58, respiratory rate 24, temp 98.9. Here's what I recommend you do. I know you already tell me the answer. That's good. But know my setting. I'm in the ER. I'm admitted with abdominal trauma after an MVA. So I know I'm at risk for hemorrhage, right? The client's vital signs are 126. That is high, low, or normal. High. Blood pressure is low, 90/58. Low. Respiratory rate 24, a little high, and temperature is relatively normal. Which of the following orders would be most important for the nurse to question? Well, this is where you could practice yourself. Like we already talked about, hey, this person, from what we can see, even this is what question's asking us, when their blood pressure is lower than 100 and their heart rate is high for them, and for this case over 100, then we're at risk for hypovolemia. So we don't want to hang any IV that's going to cause fluid to shift out of the intravascular space. And which one of that, because it says Which of the following orders would be most important for the nurse to question? Anything that puts that patient at risk. You need to be thinking through which one of these medications would cause that, and it's the hypotonic, because fluid would shift from the intravascular space into the cell, which will cause their blood pressure to drop even more. These other three solutions are all isotonic, should not cause the shifting. So that's why A, the hypotonic, remember 0.45 is definitely less than 0.9, which is normal, equal to your blood. So that was quick. Now, as we're going to continue through your memory, I want you to look at these three types of IV solutions and see if you can. Okay, Melissa, if you try signing in and out, that may be your best way to try and fix that. And I'm sorry you're having that experience. That's terrible. Okay, so we've got three types of IV solutions. What types are they? Those big categories, what could you call them? Yeah, you guys got it. Yeah, a lot of you have had this before. If you have it and you're like, whoa, 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 that was way too fast. Please go back and look at these notes. Also, take a look at our IV course on our platform, and it'll go at the right speed if you've never been exposed to that before. So what are two IV fluids that cause fluid volume to shift from the cells into the intravascular space? Can you remember? They're going to be hypertonic solutions. So just see if you can remember a name of those. Good. You guys are really doing good in the chat. I'm going to keep moving. I know it's going to feel fast. Another thing when you go back and study is think about who would be at risk to receive each one of these types of medications, because that's a really likely place for them to ask you a question. Okay, you did super well on that. And again, if you've never been exposed to IV fluids, you're probably just thinking, what just happened? Hang in there. All of us felt that way when we started studying IV fluids. It was a lot. Now let's take a look at pain control. This is a big one. Let me reemphasize with you, when you hear in nursing school, pain is what the patient reports, pain is what the patient says it is. It's absolutely true on this. Tony, you can get handouts of the slides, and we can post it again. We'll talk about how you get handouts of the slides. You get these exact slides if you want them. With pain control, even if it's a pediatric client, if you use an appropriate pediatric pain scale, then even if you don't think the patient looks like they're in pain, they should get the pain meds, and they'll test you on that. So pain is what the patient says it is. After you give a pain medicine, you have to reassess, right? You have to reassess the patient and see what's going on and see if it's effective, if you have made any impact on their pain. Now, opioid triads, what I want you to remember: pinpoint pupils, respiratory depression, loss of consciousness. Those are the three things you're looking for. I love it when you see a teenager in an ER, like, did you take anything? No, I didn't take anything. And their pupils are like tiny pins. So opioid triad, commit that to memory. You want to remember those three things are often present with taking opioids. With asthma, make sure that you know you're treating inflammation and bronchoconstriction. Remember, this is 60 seconds. For the inflammation, some type of corticosteroid like beclomethasone. For bronchoconstriction, make sure you know the difference between an acute rescue inhaler, something that works right away, and something that takes longer to kick in. With infectious diseases, antibiotics, right? You're going to give a lot of antibiotics. These have the highest risk for an allergic reaction. So any sign of a rash or itching, or they feel weird, you want to stop that medication and contact the healthcare provider on an exam. In practice, you'll learn the best way to do it based on where you're doing it. Always get cultures before you give the antibiotic. Always get cultures before you give the antibiotic. Always get cultures before you give the antibiotic. You need to have that. Also keep in mind that penicillins and cephalosporins kind of related. They're beta-lactams. So if someone has a penicillin allergy, in testing world, they shouldn't get the cephalosporin either. Not necessarily in real life, you'd ask some more questions, but in testing world, if someone says they have an allergy to penicillin, don't give them a cephalosporin, which could be saying, which of the following physician orders would you follow up on for this patient who has had a penicillin allergy? It would be anyone who has cephalosporin. Okay, always want them to have lots of fluids, stay out of the sun because several of them make you hypersensitive and everyone's supposed to stay out of the sun in NCLEX. Take the whole prescription, like complete the prescription even if you feel better. You can't take an antibiotic that kills bacteria. It has no effect on a virus. MRSA treatment, sometimes that's when you need to know. I've listed some medications there that we take in oral, and in the hospital it's vancomycin, but remember, those medications are killers, so we try only to give those if they absolutely have to have them. We talked about the medications that are ototoxic and nephrotoxic. That's in part 1. Antibiotics are part of those. Normal lab values will be there for you on your exam, but know that if we're looking at a drug that's nephrotoxic, that's what you're going to be looking at, are the renal labs. Now, hypersensitivity reactions like vancomycin, it's also called Redmond syndrome in older literature. They're trying to get away from that term. But if someone takes vancomycin and has these side effects, you need to stop the medication immediately. If someone's taking a sulfonamide and has Stevens-Johnson syndrome, this is horrible. It can kind of start with flu-like symptoms. They have this rash, and then they can just lose all of their skin. It's almost like treating them like a burn patient. These are extreme reactions and don't happen with everyone. But I've seen the reaction to vancomycin. My godson had it. It was horrible. Poor baby. Now, with fluid balance, we talked about diuretics. Remember the loop diuretics like Lasix or furosemide, that's going to drop your potassium. Diabetics can be used as a first-line treatment. We talked about that, hydrochlorothiazide. But any fluid shift when you're taking your questions, whether it's diuresis from a diuretic, or it's thoracentesis, where you draw fluid out of their belly, near their lungs, if they're doing one from their gut, anytime you pull fluid out of a patient like that, there's an increased risk for what we call circulatory collapse, and that means a blood pressure drop. So keep in mind, anytime you're pulling fluid off a patient, whether it's a thoracentesis in their lungs, you're doing a paracentesis in their belly, they're diuresing a lot with a diuretic, it puts them at risk to have low blood pressure, which also means a risk for falls. Potassium-sparing diuretics with ACE inhibitors are not a great combo, and you know that because you answered that question. So if this is someone who's getting Lasix daily, furosemide daily, which action is most important for the nurse to implement? It's the one that keeps them the safest. Do I want to look at their blood pressure? Yes. Do I want to do their daily weight? Sure, we can. Heart rate? Sure, that's fine. Assess the client's intake and output. What's going to keep them most at risk? Most safe. What's going to keep them the safest? Well, it's not their daily weight. Heart rate shouldn't be as big a problem here. INO, that's kind of extreme, but we know that taking the blood pressure, we want to pick INO because it's diuresis, but blood pressure is going to keep them safer. That's why blood pressure was the correct answer. And just for further notes, daily weight is not really a good, so it can sometimes be so inaccurate. That's why in blood pressure is a bigger deal. Bad combos, I've given you a lot of them here, and I know what time we're at. I'm going to keep trying to wrap this up for you. Low potassium and digoxin increases their risk for dig toxicity. So if a client is on corticosteroids or mineral corticoids, they can have low potassium, put someone on increased risk for dig. Same thing with furosemide. So if I'm on digoxin and corticosteroids, increased risk for dig toxicity because it can cause low potassium. If I'm on furosemide and digoxin, increased risk of dig toxicity. Just make sure you know those signs and symptoms. If you're on an ACE inhibitor, elevated potassium, with a potassium-sparing diuretic, you could have too high of potassium. MAOIs with tyramine, we already talked about this, but you got it. Ginkgo, garlic, and ginger. Ginkgo, garlic, and ginger. Ginkgo, garlic, and ginger will increase your propensity to bleed. So you don't want to take those with anticoagulants or antiplatelets. Levodopa and carbidopa, this is one that we use to treat Parkinson's disease. You don't want them to eat that with protein. So that's another one of the dietary things you should remember. So you don't want grandpa taking his levodopa, carbidopa medications at breakfast with eggs and sausage and all that protein. You want to take it away from that. Otherwise, it won't work as well. Here's a list of several of these other medications and antacids. You want to make sure you have a 1 to 2 hour window before and after an oral medication because it will impact the effectiveness and the absorption of that. If you're taking any medication like a biphosphonate or doxycycline, That can cause erosive esophagitis if you lay down immediately after taking it. So you should not take that at bedtime. Coumadin and vitamin K. Remember, vitamin K is the antidote for Coumadin. Thrombolytics, they can't have a history of recent trauma, surgery. Remember, if they have any important clots, that's going to put them at risk for death. Tetracycline should not be given to kids. Tetracyclines and teeth, so adults that are now about in their 40s and 50s, they may, if you see they have all brown teeth, it may have come from tetracycline. We don't give it to kids anymore. And fluoroquinolones can cause a rare tendon rupture in kids. So when you look at this medication about grapefruit, this was just really tough, right? And this one, you get a select all apply like that, you're like, I don't know. I do remember statins, but I don't know the others. You just keep yourself calm, do your best, and here for this case were the right answers. Did I expect you to get this? I did not. But remember, on NCLEX, you get partial credit for what you do get right. So just do your best and keep your mind under control. Because look at all of these that grapefruit juice is a bad combo. You can't remember that. And most often it'll increase the amount of drug, but it can also decrease the amount of drug. So that's not good either. We know that MAOIs don't play well with anyone. And remember, you can absolutely do this. I hope you get the notes. I hope you join us. I would love to have you. This is what we talked about. This is what's available on the Lecturio platform. If you want to check us out, and I really hope you do. If you want these copies of the slides, right here. So you have to be a member. Sorry about that. I know money's real tight in nursing school, but makes my boss much happier. Don't forget that we have these 250. These are absolutely free. One pagers. There's over 300 topics. Take care, and I hope we hear about you. Please. Oh, good. Your exam's in 6 weeks. You can do it. I promise you can do it. Bye, everyone.